question, you're gonna have to type it in the chat because I can understand that you guys can hear me, but I can't hear anybody. So if you have a question or anything, I'm having fun. If you're having any questions or anything like that, just type them in the chat and I'll see it. All right. Um, Test tomorrow. Again, remember your calculations. Go over your pearls that we've given you at the end, all of your memory joggers, calculators, please. And then for this block, we're going to talk about antiarrhythmic. So you'll see some of that heart stuff again. And then lipids, and we'll have the pain doctor come from the hospital to teach a lot of the stuff for pain management, our opioids and our non opioids. So, what we're going to start with today is going to be our lipids, and I may touch on the antiarrhythmics depending on how much time we have. But she's going to start tomorrow, so we'll just break from that lecture at that time and then pick up later and potentially cancel off days so you guys have more time again to study. All right, I'm going to start recording so that you guys can have this for later. And we'll start our lecture. Okay. All right, so hyperlipidemia is essentially when we're saying that someone has elevated lipids. There's several different things that could be elevated, several different reasons as to why they could be elevated. So, just looking at this, understanding that there are several meds that we have. The big one that a lot of people hear about is the one that we're going to spend most of our time on, but we're going to touch over a lot of these. ELOs are the same things that we've always seen before, right? So, what monitoring, not so much on your routes. We're going to be focusing again, mechanism, your clinical uses, like when am I using them? If somebody has elevated triglycerides versus looking at things that are bothering their lipids, like there's different things that we might be looking at. Okay, so just kind of understanding that each of these have different targets. So some of them they're good at lowering LDL, whereas some of them they might be better at lowering triglyceride levels. So we'll talk about that so that you understand which drugs you should be picking and which indications. And then our what do you know? And pay attention to your slides too, because like yours aren't going to be cut off how mine are cut off clearly. So, what is the drug class of choice for high LDL levels? And we're going to talk about this. This is the most important one. And this is the one that you're going to use quite a bit. We have different doses that we can use of this same drug class, and you'll get different LDL lowering effects based off of the dose. And we're going to remember those doses. So, you'll see that. Statins can be taken while pregnant is false. When we have a patient who has any type of issue with this hyperlipidemia, we will try to switch them to other medications that are safe while they are pregnant. And what class has the most triglyceride lowering effect? And that would be our fibrates. And we're going to talk about our fibrates and some contraindications that we have with some of our other medications that a patient could potentially be on. All right, looking at a little bit of our physiology. So, big thing that I want you to understand here is that cholesterol, we need it. It helps us with lots of things in our body. The problem is when you have too much of that cholesterol. And so the major lipids that we have, which is why this is called hyperlipidemia, are going to be cholesterol, triglycerides, and your phospholipids. So um, when you're looking at hyperlipidemia, that could be several different things because we have several different types of lipids. And then that's all I needed you to know from this slide. This is just giving you background about how they're transported throughout the body, all that. I'm not asking you guys about any of your pathophys questions. And then this is a part of our physiology that is very important because we have different ways that we can get cholesterol. Either it's going to be endogenous, meaning my body is making it itself and it's coming from the liver, or exogenous, meaning that I got it from my diet. Um, diet does play a role in hyperlipidemia, but not as much as what people's bodies do. It can tip, though, the way that things are going for your patient. So we always stress diet. Looking at your endogenous, you'll see that we have that HMG-CoA that converts your mevalonic acid or your mevalonate by that reductase. Okay. And so our reductase is what we target when we're looking at our statins. We're trying to prohibit that cholesterol formation that is endogenously happening. So you see in the on the in the photo where it's circled red, and you see your HMG CoA reductase in red, and then you see where it has the statin, which is our drug class that we're going to talk about, being blocked, being sorry, not being blocked, blocking your reductase so that we don't have the end result, which is also in red, which is your cholesterol. So this is going to be your mechanism of action when we're talking about our statins. Okay. Now, we have several different lipoproteins. And so, this, I just want you to know that there are different ones. You have your VLDLs, your ILDLs, your LDLs, and your HDLs. The ones that we focus on more when we're targeting things with drugs are going to be your low density lipoproteins, so your LDLs, and your HDL, which is your high density lipoproteins. And just simply put, your LDLs are your bad ones, and your HDLs are your good ones. We have some drugs that, by like inadvertently, will increase your HDL levels. HDL levels are something that you'll look at, but you're not necessarily going to give a medication to increase them. But some of our meds will increase our HDL levels. So most of the time, we're going to be targeting and trying to get down that LDL level that you'll see elevated in your patients. All right, let's keep moving. So again, some more terminology for you to look at and kind of be familiar with. This is just letting you know that if somebody has hyperlipidemia for a very long time, it can cause several problems in our patients and cause other diseases and vascular diseases, which we don't want. Coronary artery disease. So we do try to get those levels down as soon as we possibly can, and sometimes very aggressively. Hyperlipidemia is just telling you that this is saying, hey, it's a high level of those lipids in the blood. And then dyslipidemia is saying that you have either a high level of your LDL or a low level of your HDL. Because remember, we want the HDL to be high, and we want our LDL to be low. So this is just saying, hey, that's called dyslipidemia. It's not regulated. So I think of it as being dysregulated, making up some things so that you can remember. All right. So this is a picture of kind of what happens with atherosclerosis. So when you have atherosclerosis, you'll see that some of that plaque starts to build up along the wall, and over time, the way you can think of that is it makes that cap, and then it can eventually rupture, especially if that cap is thin. And so what ends up happening is you start to get your damaged endothelium, and then you have nitric oxide that starts to decline, your prostacyclin starts to decline, and then that's when we see a lot of those health conditions that we discussed before kind of appear. So just understand that this is something that we don't want happening. On your left, you see that thick fibrous cap, meaning that it's a stable plaque, but again, not great because you see that it's not a wide open water hose. Like we want that to be open so our blood and everything can flow through it. But when you see this, this is like now occluding it on that stable plaque. And then on your ruptured plaque, what happened was it was thinner. That cap was thinner, and then it ruptured, and then you start to get buildup there as well. And a thrombus can form, which is kind of what you guys have been talking about in the first block. And then we have issues with trying to clear that. So just be aware that there are several things that can happen that are not good. We don't want those things to occur. So all of that, not testable, just your background so you can kind of understand where things are working. And now we're going to get into my favorite part, the drugs. Okay, this is where we're testing. So there's several different guidelines. There are different guidelines that have been updated recently. AACE is one of them, and they've released 2025 guidelines, but we're not going over those because those won't be on your exam. These are the ones that will still be on your exam whenever you're taking them, for the PANCE as well as mine. Looking at this is just important for you to remember to annotate what guideline you are using when you're choosing to practice, because there are several. When you look at your ATP guidelines aren't as stringent with their goals as your AHA and your ACC. So just paying attention to which one you're looking at is going to be the big deal. VA, clinical practice guidelines, which is what that CPG stands for. We also will have different guidelines based off of what we typically would do if you are practicing within the DoD. So just again, be aware of different ones. Not going to ask you about them as far as like what the goals are, but you will see them, and you'll hear me as we continue to go through these, talk about the target goal of being less than 70 for our LDL. So that's the big thing that I want you to remember here, is that our target is going to be less than 70 for LDLs. All right, next slide. So again, this is a big part of us knowing what we're going to do and how we're going to treat our patients. So you can go online and they have what's called a risk calculator. And you would take all of the information, which is what you see on the right hand side, and you would put it into this calculator. And then it's going to spit out a percentage to you. I don't need you to remember all of the things that are on here, but I do want you to know that what it is telling you, this risk calculator is telling you the 10-year risk of that patient having some type of cardiovascular event. Right. So if I know that this person, because we said the longer that they have the hyperlipidemia, that we can have several different things happen to the patient. So this is telling you, hey, you need to be more aware, or treat this patient a little bit more aggressively because they are at an increased risk of having that cardiovascular event. So you see non-modifiable, essentially, this is the way that people are born, versus your modifiable, things that they could potentially change or make better. If there's an underlying disease, please, of course, always make sure that you're treating that underlying disease state. And then looking at the use to access the need for your statin therapy. So again, this was just saying like, hey, depending on how your patient presents, are there any other underlying health conditions? Yes, I need to treat my patient, versus not so worried about them. And your calculator will give you that percentage after you put in all of this information. Okay, come on, progress. So statin benefit groups. So I told you when we're looking at our LDL, this is the biggest um, drug and the most powerful drug that we have, our drug class, sorry, that we have to use for this disease state. So when you're looking at this chart, what I want you to see is that let me get my little pencil. It'll let me. This little line right here is dividing when you're using a high intensity statin versus using a moderate intensity statin. Okay. So when you're looking at this, anybody that has ASCVD, anybody that has an LDL number that's over 190, or when you put their risk into that calculator that we talked about, it comes back and it's 20% or greater, and they're over, or they're in between the ages of 40 and 70, you're also going to put them on a high intensity statin. So this last box is important to note that it says and, okay? So their ASCVD risk is over that 20% and they're in that age range, okay? So 3 things will put you in that high intensity statin group. And then when you're looking at the moderate intensity statin, the moderate intensity statin is going to be your patients who are between the ages of 40 and 75 and they have diabetes, or their risk score, the ASCVD risk score, again, the thing that we typed in the calculator, is greater than 7.5, but less than the 20%. Because remember, the 20%, I'm going to put them in my high intensity statin. Okay. So just make sure that you're paying attention to what's going on. And this is a summary of this next chart that we're going to look at, which is kind of overwhelming when you see it. But if you refer back to this and if you can walk your way through this other chart makes sense a lot more. So head over to our next slide and you'll see this is titled primary prevention. I want you to pay attention to that versus secondary prevention. So primary prevention is meaning that your patient does not have ASCVD. Okay. They don't have anything going on. They're fine, but they might be at risk. So when you're looking at this, you're trying to say, all right, how do I treat my patient? So I'm going to walk us through this. I don't know if you can see. Can you guys see this pointer? If somebody can hit a thumbs up or something, I just want to make sure you can see. Yes. Okay. So on along this side, you see 1, 2, 3, 4, and then 5. So our 1, 2, well, these over here, essentially, I'll say it that way. These are the ones that we saw in the previous chart. So this is saying their LDL is greater than or equal to 190. They need a high intensity statin. I don't care about my ASCVD risk calculator. I don't need to put in anything at all. So think about Monopoly when you see those three things, right? You don't pass go. What did it say? Don't pass go and collect $200, go straight to jail. This is, they're not collecting anything, okay? They are getting a statin, and it's going to be a high intensity statin because their LDL levels are very high, okay? So your magic number is greater than or equal to 190, high intensity statin. Now, if I'm telling you that I have diabetes and I'm between the ages of 40 and 75, they can get a moderate intensity statin. Now, you will hear some people be more aggressive, and if your patient is younger, they will go to a high intensity statin. But this is a consider. They must have the one that is in green. So at the very least, they have to have the moderate intensity statin. Okay. Most of the time, you will hear people being a little more aggressive lately, and they could potentially, and it's not abnormal for you to see a high intensity statin, especially if you're looking at rays. People want you to learn their diets and how they eat certain things. It may make you lean more towards a high intensity, but again, you don't have to. And then over here, you see your patient who could potentially have any of these things, right? But if they're over the age of 75, you're kind of like, let me let them live the rest of their life, right? Like you're just having a discussion with that patient. Now, if they were on a statin prior to turning 75, you can leave them on that statin. And we'll talk about the adverse effects of our statins, but a lot of times patients will have myopathies and they could have rhabdo as well. And so you don't want to give this to a patient who's over the age of 75, especially like a high intensity statin, because they're more likely to have adverse reactions from the medication than a younger patient. So that's why you see that 40 to 75 age group. But anybody who's over here, so if they have diabetes, those LDL levels are over the 190, greater than or equal to 190, I don't care about my risk calculator. You don't have to pull out your risk calculator to do anything for them. They automatically want a statin. Now, going back over here, this is just going down the different pathways. Remember, our target age is 40 to 75. So your 0 to 19, these are just patients who you have who are probably genetically predisposed to having some type of hyperlipidemia, and those patients will be placed on statins. This is not going to be your typical population that you're going to deal with. And then your 20 to 39-year-olds, again, this is just, you can look at them and say, hey, it's a consideration because we know that you have a family history or they've had like any type of LDL levels that look like they are high, but they're not extremely high to where they're at that 190, and they haven't hit that sweet spot age between the 40 and 75. So you can kind of play with them. You can put them on one if you want, but not a requirement. Our big focus is going to be this 40 to 75. So your 40 to 75 age group, right? Their LDL levels are over 70. Remember that they're over 70 because our 70 was our target. Okay, so they're greater than or equal to 70, but they're less than the 190. Because if I am at 190, I don't need to do any of this stuff that I'm about to talk to you about. If I am at 190, then I'm already getting a high intensity statin. Okay. So here I'm at my 40 to 75. I'm between 70 and 190 with my LDL level. I don't have diabetes because remember, if I had diabetes, I would be on my moderate intensity statin if I was in this group. Okay. So you have your 1 and 2, which were your automatic, you can knock them out. You don't care about the calculator. Once you hit 40 to 75, and they're between that 70 and 190, now you care about the calculator. So I go in, I put in my modifiables, my non-modifiables, and the calculator spits out something. Less than 5%, I'm low risk. There's nothing that you need to do there. Just tell me to lifestyle modifications, right? Exercise, make sure that I'm working out, all of the things, make sure that I'm eating healthy. And you can also send them to nutrition if you wanted to. Less than 7.5, they're at borderline risk at this point. But you could potentially say, I want to give you a moderate intensity statin. And that's based off of if they have one of these risk enhancers over here on the side. On the exam for me, if I am giving you a patient who has a risk enhancer, I will just straight up tell you they have a risk enhancer. I won't say that they have a family history or that they have CKD or anything like that. I will say their ASCVD score is 6% and they have a risk enhancer. Then you're going to want to talk about putting them on a moderate intensity statin. It's one of those discussions. Now, you're over 7.5, but you're less than 20%. So if you're in that range, you're at an intermediate risk. And what you're going to do at that point is say, hey, I want to give them a moderate intensity statin. You'll see here that it says the LDL will be decreased by 30 to 49%. And we'll see that on another table later. Just moderate intensity statin is all you need to know from here. And then if they're over 20%, which was on that previous slide, right, where we said the ASCVD risk was greater than 20% and they were between the ages of 40 and 75, that we were going to give them a high intensity statin. So there's your high intensity statin. So this chart, you will remember, I like to look at the slide beforehand to say, hey, when am I at high and when am I at moderate? And that is a summary essentially of what you're looking at here. Over the age of 75 is a discussion. If they're less than 40 years old, they have any type of history, anything like that, we have discussions. If we diagnose them with any type of familiar hypercholesteremia, that will be a statin for that patient. So this looks overwhelming. Again, if I give you a risk enhancer, I'm going to tell you that it is a risk enhancer. And then you see down here, this isn't me, but just for completeness, we have what's called a CAC score. And what they do is it's a procedure where they go in and it's a coronary artery calcium test. And it's a CT of the heart to see if they have a chance of having a heart attack. And you get different scores. The lower the score, the better it is for that patient. So if they have like a 0 or very low risk, you don't really need to do a statin for that patient. Unless they're in that age range where they're the 40 to 75 and they have diabetes, then that's whenever you would consider it. Family history, things like that, you could potentially consider it, but most of the time they won't do that. So just be aware of the CAC score. Y'all will probably talk about this whenever you're in cards, but the higher the score is, the more likely you are to initiate a statin for that patient. Okay, next slide. So when we're looking at this slide, this is now telling us secondary prevention. Secondary prevention is saying, hey, your patient does have ASCVD ASCVD. They've had some type of event that has happened. And now you're trying to say, hey, I know they had this atherosclerotic cardiovascular disease. They had some type of event where I had that plaque buildup and it caused a heart attack, a stroke, what have you. They had some type of issue that occurred. Now they're going to likely be on a statin because we know that they have had some type of event. Okay. So your first slide that we just went over, your primary prevention was saying, hey, before this happens, I want to prevent it. This secondary prevention is saying, hey, they've already had some type of ASCVD risk event, and I don't want anything else to happen. That black box, I need you to remember on this one because I won't tell you the difference between your very high risk and your not very high risk. So let's go down here. So they've had some type of event. Always we talk about lifestyle modifications. But if I have ASCVD and I'm not at very high risk, I'm less than 75 years old, guess what I get? I get a high intensity statin. You are very worried about me because I had, let's say, a heart attack. Okay. So I am worried about that patient, high risk statin, high risk, high intensity statin. Now, let's say that I gave my patient that high intensity statin and they couldn't tolerate it. They came back to you and they were like, hey, doc, I'm having a lot of pain. My muscles are hurting. Like, I can't do this. I don't want to take this medication anymore. If that is the case, then you can decrease the dose to a moderate intensity statin. But that is not what we will do first. So in this situation, we're not, you'll hear me say sometimes start low and go slow. This is not that situation. In this situation, we're saying you've had some type of event. I'm aggressive initially. And then if you come back and you complain to me about any of those muscle pains, then I will decrease that dose. Okay. So not something that you tell the patient like, hey, I'll give you a lower dose if you come back and tell me that your muscles are hurting. But you do need to let them know about all of the adverse effects of statins because they can happen. And we do have to get creative sometimes with our dosing of statins. Now, if they're on the highest dose, so their high intensity statin that they have, and their LDL is still above that 70, which is our goal that we said that we were trying to get them at, then we will consider adding ezetimibe or Zetia to that. So what ezetimibe is trying to do is further lower that LDL level so that we can get them to the target goal, which is to be less than 70. Okay. So if I am less than 75, I had some type of event, but I'm not at very high risk, I'm on a high intensity statin. If I can't tolerate the high intensity statin, then you're going to decrease my dose. If I'm on my high intensity statin, but I'm still not at goal, then you can add ezetimibe. If I'm over the age of 75, remember, you trying to let me live my life. We already talked about it in primary prevention. We said we will have a discussion. In this patient, we want them to live their life, right? So we need to put them on some type of medication because we know that there's buildup. We know that they are at an increased risk now of having that event, especially after they've had one. So you are going to put them on a moderate or a high intensity statin. Most of the time, you will see us in this patient population start with the moderate intensity statin. Depends on the risk factors for that patient. But again, remember, we're saying that these patients aren't at a very, very high risk. Okay. So you are worried, but not worried. And sometimes you'll see where if they tolerate that moderate, some people will try the high just to see what happens. If they were already on a high intensity statin, you can continue them on their high intensity statin. Looking at our very high risk, these patients, they had some type of ASCVD event, and they have some type of high risk condition. So over the age of 65, familial history, diabetes, or a smoker. Now, this depends on how you're looking at this because some patients, if you are saying the over 65, this depends on, and I won't ask you this on the exam, but this depends on how your patient is and how well you know your patient. So for the exam, I won't use that age for that high risk condition. You'll just see me with the familial disease, diabetes, or if they're a smoker. Give me 1 second, y'all. So sorry. Okay. So when we're looking at this, hold on, that question. If they can't tolerate, but LDL is less than 70. So if their LDL is less than 70, then that means that you're at your goal. You can in there if they were on a high, you could potentially step them down to a moderate, but just once they hit goal, that does not mean that we can take them off of their meds. We will usually leave the patient on their medication. So yes, if they can't tolerate and their LDL is less than 70, you can lower the dose for that patient. And let me know if that didn't answer your question. Okay. And then, so for our high intensity or our very high risk ASCVD patients, they're going to get a high intensity statin. And then, if they're on the maximum dose that they can have for that statin, they're the ezetimibe first before we do that. But it just, so we will, uh oh, can you guys hear now? Yes. Okay. You are back. All right. So remember that you're trying to add on your ezetimibe before you add on your PCSK9 inhibitor. So our order of things is going to be a statin, maximum dose of that statin that your patient can tolerate, ezetimibe, and then if we're still not hitting goal, then you can add on your PCSK9 inhibitors. Going any further than that, I will talk to you about some situations that we've had. We've had patients who could not tolerate statins, so we put them on ezetimibe and a PCSK9 inhibitor initially. I'm not getting that creative with you guys. Like, just remember the basics: statin, ezetimibe, PCSK9 inhibitor, and then you see how it says like their maximum tolerable dose. So we do have high and low intensities, but we also have to remember if our patient can tolerate that medication or not. Okay, so we'll keep that in mind as we continue to go through. This is a slide just showing you all of our different medications that we have that try to get those lipids back under control. So this is just a summary slide giving you those 4 subcategories of treatment options that we have. So you have your HMG-CoA and enzyme reductase inhibitor, which is going to be our statins. These are going to try to alter how our lipids or our lipoproteins are metabolized. So we have niacin, fibric acid derivatives, PCSK9 inhibitors, and our fish oil. Then you have bile acid sequestrants, which we'll talk about all of these. These are our C drugs, and then your cholesterol absorption inhibitor, which is your ezetimibe. And this was the drug that we kept adding after we got them on their statin if they still weren't at goal. Okay, so keyword is that they are not at goal, and that's why we're adding the cholesterol absorption inhibitor. This is a chart to kind of hammer down where we're looking and what we're trying to target depending on how our patient presents. So if somebody has LDL levels, our statins and our bile acid sequestrants are the best drugs that we have to combat that issue. We typically will lean towards our statins, and then your bile acid sequestrants are like second line. So if I couldn't, for whatever reason, tolerate a statin at all, and I'll tell you the ways that we get creative with the dosing, then this is something that I could potentially go to. If somebody had triglyceride issues, you see that our fibrates are better. And then you have niacin, then a close second. Niacin has its own issues that we'll talk about. Most of the time, it's not well tolerated. So you'll see that the fibrates are typically where we'll go. So it's good to see the positives, like when we're talking about the niacin with that HDL increase. But again, when we talk about niacin, the flushing, all of those things, sometimes our patients might not be able to get titrated up to the dose that we need them to get to. Our CAI or our ezetimibe, you see, that's why we were kind of adding that on just, to kind of further get us a little over the hump if we weren't there, because it does have, you know, activity. It's just minimal activity. But it does work very well, and we do see good results whenever we're using this drug. All right, this is your money slide. Okay. This is you remembering your high intensity, your moderate intensity, and your low intensity statins. You have to remember these doses because you could just get questions that say like, "Oh, which of the following is a moderate intensity or a high intensity statin?" Also, you read a guideline, and if you don't know the strength of that statin, then you don't know which one you're prescribing. So understanding this, and you will also see this again in cards, understanding where your high, moderate, and low intensity statins are very important. What you will see when we're looking at this as well is that different tables may have a slight fluctuation when you're as far as what falls into moderate versus low intensity. But for the most part, we don't really use low intensity statins very often. Very rarely do we see those used. Most of the time, you're going to be in the moderate or the high intensity statin classification. I told you on that chart when we were looking at like the flow. So going back to, let's see, slide, I want to say 16. So here, oh, come on, whenever it was telling you, oh, intermediate risk, decreasing the LDL by the 30 to 49% or decreasing that LDL by 50%, this is what I was telling you that you would see whenever we were looking at these statins, right? So now you see, based off of the intensity that I pick, that is the lowering effect that I'm getting. I don't really focus on that with you guys. What I'm focusing on with y'all is knowing what drug falls into which category. So my high intensity statin is AR, atorvastatin, rosuvastatin. You have to remember the dosing on this, and I never really make you guys remember dosing because you'll see that you also have atorvastatin and rosuvastatin in your moderate intensity, but at a lower dose. It's half of that. So your atorvastatin, 40 to 80 milligrams, and your rosuvastatin, 20 to 40 milligrams, is going to be your high intensity. So I remember those two as like an AR, right? Like it's a high intensity weapon. Okay, so atorvastatin, 40 to 80, and then rosuvastatin is half of that, 20 to 40. All right. That is your high intensity statins. You see that says doesn't require bedtime administration. That's because a lot of the times we will tell our patients to take their statin at night because that's when they're more effective. That's whenever we see a lot of our lipids being produced and made by our endogenous system or the liver. And so we tell patients to take them at night. With our high intensity statin, because they're at such a high dose, it doesn't matter when they take them. So your moderate intensity statin, you see your atorvastatin, rosuvastatin. We have simvastatin. Simvastatin used to be very, very, very popular, but now we don't use it as much because it has a poor side effect profile. But you will see also that in newer guidelines that continue to come out, they like our atorvastatin and our rosuvastatin more than a lot of our other statins that are available. But there are times where some of these others are useful, and we'll talk about those when we go through them. So your simvastatin, pravastatin, lovastatin, fluvastatin, and pitavastatin, these are ones that are not as commonly used, but you will see them again in some situations. And then your low intensity statin, you again see your simvastatin here, but it's half of the dose that you see in your moderate intensity statin, so 10 milligrams. And then your pravastatin, lovastatin, and fluvastatin, also again, half of that dose of what you saw in the moderate intensity. So the way that I tell people to remember this, remember your high intensity, remember your low intensity, and everything else falls in between. Just make sure that you're looking at that. So high intensity statin, atorvastatin 40 to 80, rosuvastatin 20 to 40, your low intensity statins, simvastatin 10, and then you're going to go to your pravastatin, lovastatin, fluvastatin, and those are half of, if you keep looking, they're half of what you see in the category ahead of it. All right. So, big thing here, know what falls in what intensity. The ranges are also important because you can't just say, oh, I know rosuvastatin is high intensity, because what if I told you it was rosuvastatin 5 milligrams? That's not a high intensity. That would be your moderate intensity. So that's why I'm saying on this, a dose is important. And I guess I shouldn't say a dose. The strength is important for you to know. I see a question coming in, but we'll move until it gets typed. All right. So going into our next slide, this is again our statins. We talked about how they work. So they're trying to stop or inhibit that step in the conversion of the cholesterol. So we're trying to stop the reductase. So that's where you see the HMG CoA reductase inhibitor is what we're doing with our statins. Therefore, you'll start to see a decrease in the amount of cholesterol that is being produced, and you'll see more of those LDL receptors kind of pop up on the cells to get that LDL out of circulation, so out of the plasma. So inhibiting the reductase then leads to less intracellular cholesterol. We have an upregulation of those LDL receptors, which reach and snatch it out of our plasma, and then you'll see lower LDL levels. Okay, so good again for our patients who have high LDL, not improved for our children who are less than 18, but you will see sometimes that they are on a statin. And so that would be something that you're referring. Most of the time, that wouldn't be you that's dealing with that. Looking more at our clinical effect, we already talked about this, best for lowering our LDL, reducing a lot of those reducing mortality events, decreasing the chances of them having any ASCVD events, so the stroke, any major coronary events that we could potentially have. Looking at the dose and administration, remember I told you that we try to tell patients to take it at night because that's when most of that cholesterol is being made, but we don't really worry about our high dose of atorvastatin and rosuvastatin because again, they're high dose. And then wait at least a month before you change it. And some people will do 4 to 6 weeks. It just depends. Make sure that you're waiting before you actually change a dose or feel like you're not reaching your goals. So if you see that they're still not at that 70 mark or less than 70 where we want them to be, again, make sure your patient is taking the medication because if it's still in the bottle, that makes sense as to why we're not at goal. But you want to make sure that you are looking at if they have been taking that medication. But before you change it, give it an adequate trial of at least 4 weeks at a bare minimum. And there, at that point, you can start to change it. Adverse effects, these are the things that I kept touching on. So myalgia, myopathies, rhabdo, you can see all of these things occurring. So the big thing is asking your patient if they're experiencing any muscle pain, and then the potential of you monitoring or measuring their CK levels. So we do get a baseline CK, and then we get other ones if they start to say like, hey, I'm experiencing muscle pain. You will pull again at that point. So don't say, well, I took it at baseline and you are fine, so I'm not checking it again. It's always something that's very easy for us to pull if the patient has any issues. So just understand that you're pulling the creatinine kinase. I don't need you to remember the 10 times the upper normal limit. Just remember the CK. CK is the lab that we're doing. You're going to get it at baseline, and then you're going to do it again if your patient ever says that they're having any type of symptoms at all. What else did I want you to take from this? Oh, your LFTs. So you're going to monitor your LFTs. Remember, we said that we would do these again at baseline, but we don't do any dosage changes until that 4 to 6 weeks happen. But also, we would bring them back in to see how they're tolerating the medication. Make sure they're not having any of their muscle problems. Also, to check their LFTs, because sometimes what we can see is a bump in their LFTs, which is okay as long as it doesn't stay that way long after. So you can see that transient rise of those LFTs when we initiate statins, and that's perfectly fine as long as they go back down. So that 4 weeks of bringing them back in is very important. And some providers, because they've had issues with this, they will bring patients in sometimes more than that to get another level. So this is a chart just showing you, again, a summary of what we talked about. So your fasting lipid panel, this is something that you're going to do all the time because that's what we're monitoring. That's why we're giving them drugs, right? So at baseline was you discovering that they had some type of issue. 4 to 12 weeks after initiation, just to make sure that your drug is actually lowering, right, those lipid levels. And then looking at your every 3 to 12 months. Most of the time, once your patient is stable, you're only going to check it once a year. But if your patient isn't stable or you keep changing their dose, this is where you'll see them coming in more for that panel. Your LFTs, your AST, remember baseline 4 to 12 weeks, you'll see that. And if they complain of any type of hepatotoxicity, which is also another adverse effect of our statin, you will see that we will pull those levels at that point as well. But most of the time, once you have that 4 to 12 weeks and your patient isn't complaining of anything, you're okay. Your CK, again, pulling that at baseline. And if your person tells you that they have any issues, any muscle pain, that's whenever you're going to pull levels again. Other than that, you don't need to. Here are some of the different factors that we have that can increase the risk of a patient having myopathies. So, again, we already talked about that over the age of 75. If they're female, any type of renal or hepatic dysfunction, we can see that. Hypothyroidism, and we'll talk about the thyroid later, but it plays into so many different things and parts of our body. Grapefruit juice, alcohol, right? Things like that, because grapefruit juice can interact with some of our medications. Alcohol just could also cause different types of myopathies as well. And then Asian ancestry predisposes our patients. Looking at your statin properties, that is why we have the interaction. Not going to ask you so much of this, but just understanding that the way that the drug is, because it gets into our system very well based off of how it is made, with that bioavailability. It is very potent for some patients, and so it does penetrate a lot, get to where we need it to go, and that's how we see those myopathies occur. And I told you that we have lots of different ways that we are going to get creative if our patients say, hey, I can't tolerate that statin. So we have the intolerance. What you could do is change them to another statin. Your patient comes in, hey, doc, I'm experiencing pain. I don't feel good whenever I'm taking this med. What do I need to do? So you can give them a different statin. You can change the dose. You can give them every other day dosing. Every other day dosing. Just make sure that if you write out that prescription, you put the day that you're telling them to do. So if you're going to pick Monday, Wednesday, Friday, Sunday kind of thing, like they know what day they're doing it on. We do this. You will see this. Sometimes we'll even try to go to every 2 days. Like you will try to stretch it, because them having a statin on board is better than them not having the statin on board. And just because one doesn't work doesn't mean that that entire class won't work. You can change them to something else. So again, if they are having any type of muscle pain, we're going to tell them to stop it. We do our workup with our labs. If they're having mild to moderate symptoms, same thing, stop it until you can evaluate it, make sure everything is okay. Those other conditions that we talked about, that could potentially be also causing myopathy, we want to make sure that those are eliminated. And then if there's nothing else that is going on with that patient, you could try to lower their dose and put them back on the same statin to see if those symptoms come back again. If it does continue to happen, of course, take them off of the statin, and then you can put them on a different one after their symptoms resolve. Um, at that point, you can slowly increase their dose and then see where they start to have the symptoms again. Somebody can also be taking the statin for years and have this all of a sudden start to happen. So just be aware of that random flare up that your patient can have and that they tell you about. It can be something that they've been on for a long period of time and they still just randomly had a reaction or develop that intolerance to your statin. And then you're going to have to change what you're doing at that point for your patient. So remember, this is a thing that happens in a lot of our patients. And if it does happen, you have ways around it for us to make sure that they're still being treated. Looking at our considerations that we have, so making sure that their renal function is fine, because remember, we are looking at having to change doses and monitor more frequently because we could have buildup if they have that reduced renal function. The only ones that we are not worried about are AP. atorvastatin and pitavastatin. So the pitavastatin was one of the ones that was in the very bottom of your moderate intensity statins. And I told you they're not used frequently, but you can see where there are some situations where we might need to use them. This is one. Your patient comes in, they have poor renal function. Ta-da, I have a medication that I can use. But most of the time, we'll go to atorvastatin first. So atorvastatin is usually where we're going to go first. Your protein binding, all of them are highly bound except for your one that starts with PR, okay, Prevastatin. Because remember, you have others that start with a P, like your pitavastatin, but your Prevastatin is the only one that doesn't have high protein binding, PR with PR. What that means is you could be giving your patient a medication like their Coumadin or their warfarin, and it could displace the warfarin because now they're competing for that binding. So they've displaced your warfarin, and now you have a higher risk of bleeding because you have warfarin just floating around in the system. Okay. So that's where you'll see, oh, maybe I can put this patient on Prevastatin instead because they have warfarin on board. So that is an interaction that you need to make sure that you're watching out for and understanding, hey, if I have any of my other drugs that I tell you, if I tell you a drug is highly protein bound, then you are going to want to reach for Prevastatin if your person needs that LDL lowering. And then if I tell you that there's something wrong with their renal function, AP, atorvastatin, and pitavastatin. Okay. Those are our two drugs. I'm trying to get us to a good stopping point. I don't think we're going to have one. Let's go ahead and take our break. And then when we come back, we will finish this. So come back at 09. Okay. All right. So now this is going on more of our interactions that we have. And I told you very rarely do y'all see us put absolute or relative contraindications on the slides. This is one of those that you'll see the absolute contraindication being the acute liver disease, and also the reason for this is because remember, our statins can cause an increase in those liver enzymes, right? So we want to make sure that we're not making that any worse for our patient. So absolute contraindications. Make sure you're looking at your liver disease, and I still won't word it that way. I'll probably just ask you about a contraindication, and you'll see one thing here if I asked you that. Looking at your relative contraindication, what you see here is if you have an inducer or an inhibitor of your CYPs. Remember, I don't need you to remember the specific CYP. Just know if they're induced or inhibited, I won't make up the CYP name. I would just tell you what's going on. But if you see that, then of course, like any other drug, you're going to have issues. And we'll go over specific examples in a little bit. And then if someone is pregnant, most of the time we're going to tell our patient to stop the statin. It depends on what is going on and why we would continue a statin. Most of the time, this is a risk versus benefit discussion. Prevastatin, again, is one of our ones that is the safest because, again, it's the one that has the least amount of binding, and that's the one that we've done studies in to see that it's the least likely to cause harm to the fetus. You can, in a pregnant patient, do lifestyle changes, give them a bile acid sequestrant as a good alternative to a statin. But for the most part, our patients are not going to use this in pregnancy. Your patients who are high risk, those people who have strokes, heart attack, family history, those people are the ones who you will see that are left on them. But again, this wouldn't be a you problem. They're probably going to be dealing with somebody else and not you. If you know that your patient is starting or trying to become pregnant, and this is with most medications, you would look at that PLLR and say, hey, is this something that would be safe in pregnancy? Because if it's not, then I should probably prescribe something else if I know my person is trying to become pregnant. So this is the same thing, just making sure that that you know if they're trying to become pregnant, because if they are, typically we would tell our patients to stop taking that statin a month or two before they are trying to actively become pregnant. If they are nursing, it can go into the breast milk, and we don't want that to happen. So we would take caution in that situation as well. So they shouldn't be using it. So overall, your idea for pregnancy is that they are not using a statin unless they are high risk. We have other things that we are going to do in that situation, like a bile acid sequestrant on top of those lifestyle modifications. Looking at your interactions, so our SIP that we talked about, we have a lot of good data showing that our pravastatin and our fluvastatin are the least likely to have those interactions. So those are very good for us to use those two drugs if we have SIP interactions that we worried about. Um, if you're looking at a grapefruit juice, this just the amount varies. Some people, they can drink a little bit of grapefruit juice and it can affect them. Some people, they have to drink a lot of it before it affects them. But essentially, them taking or drinking grapefruit juice can increase the risk of them having myopathies. So we think about grapefruit juice. I used to think about like, oh, there's someone's grandparent or an older person who drinks grapefruit juice. But you think about Sunday Fun Day, people drink mimosas and they use grapefruit juice, okay? In that 40 to 75 age range. So make sure that you're paying attention to that and telling them, like, hey, you need to make sure that you're not using taking the grapefruit juice when you're taking these three statins. These are the ones that you will see where the metabolism gets decreased, and then you increase your risk of those side effects like the myopathies. So atorvastatin, lovastatin, simvastatin. Um, Sal likes grapefruit juice. Simvastatin, atorvastatin, lovastatin. That's how I remember it. Okay. Red yeast rice. Red yeast rice is a dietary supplement that they can buy over the counter, and people believe that it decreases their levels of cholesterol. Some people will try to get red yeast rice before they come to you. You need to make sure that they have stopped taking the red yeast rice before you put them on a statin, because it can, again, increase the risk of the myopathy and the rhabdo if they're taking them with their statin. So just make sure that they are not taking those two things together. Red yeast rice over the counter, no with your statin. Grapefruit juice depends on the patient, but Sal likes grapefruit juice. Simvastatin, atorvastatin, lovastatin are the ones that are affected the most. And then if you're worried about your SIPs, flu and pravastatin are where we're going with those. All right. Now we're looking at some more interactions that we have. And this is looking at your fibric acid derivatives. When we talk about our fibric acid derivatives, this is another drug class that we're going to look at. But essentially, if you're giving these with a statin, what can happen is the increase of the rhabdo and the muscle pain. Same things that we keep talking about. Okay. So if you are going to use these two together, very tricky thing. Most of the time, they will be in with a specialist to do this. But the biggest one that we want to watch out for with our fibric acid derivatives is going to be your gemfibrozil. We are not going to use this with any of our other statins. And the same thing with our niacin, because not only do you have the increased risk of those myopathies, you also see that you have the increased risk of the hepatotoxicity or the liver toxicity. Okay. So make sure that you're remembering gemfibrozil and niacin with a statin. We have those increased risk of side effects. Niacin of the myopathy or the rhabdo. Niacin also is so nice that it adds on hepatotoxicity to what could be increased if you combine it with a statin. Okay. So other things that we have that can interact: amiodarone, dilt, verapamil. Y'all have talked about some of these. Amlodipine. Again, the increased risk of the myopathy. So pay attention to this slide, very important slide, because you can see sometimes where these things are happening and we don't pay attention to them, and your patients are going to present with those myopathies. This is a slide that is giving you what the interactions are. I just need you to know the agents. If you would like to see the recommendations as to what you should do, that is fine. I'm not going to ask you that. I'm just asking you those agents, which are the things that we kind of talked about on the slide prior to this one. So again, I don't need you to know what the big things are as far as the recommendations, just the agent. Know your agents. All right. So, different class now. We're in our fibric acid derivatives, which we also call fibrates. What they're doing is they're working on the PPAR. So, PPAR stimulates lipoprotein lipase to break down and remove like LDL, all of our bad things that we have, VLDL, our lipoproteins. Um, when we look at this, it's very good for lowering our triglycerides, and we also get a small benefit of an increase in that HDL going up, which remember your HDL is your good one, and we want to see that. This is going to be a second line to a statin. Remember, we wouldn't use it with a statin, especially our gemfibrozil. On here, you see the different agents that we have. Fenofibrate is one that we could potentially see used with less interactions if you had to use it with a statin, is the fenofibrate, which is the second bullet that you see, second main bullet that you see under the agents. Our clinical use, again, just the big one that I want you to remember is that it's lowering our triglyceride levels, second line essentially to your statins. And then you see if for whatever reason they can't tolerate a statin, this is our option. Second line, second line, second line, second line. Next slide. So looking at our adverse effects that we have, again, we see the same things that we talked about with that myopathy in the rhabdo that we saw with our statin. So that's why when we have that gemfibrozil on board, you're more likely to see that happen. You can potentially see it used. Remember, I'm not telling you that you won't. If you had to do it, fenofibrate is the best one to pick, and you're going to monitor those LFTs more frequently because you have two drugs on board that can increase the risk of having that myopathy now. You also see that headache, rash, GI malignancy can potentially happen. Controversial topic, it will continue to develop. Just understand that it's there as a possibility. Our monitoring, if you're going to administer it with that statin, that's whenever we're going to continue to look at those LFTs because we have that increased risk. Pregnancy, if you have somebody who is pregnant and they're one of your higher risk patients, you can see the fenofibrate being used. Again, second trimester is where we would like to add that on. And then our interactions, we already talked about this. Looking at your gemfibrozil, we are increasing the risk of the myopathies because now that statin isn't being cleared from the system the same way. You see that we have fenofibric acid or Trilipix that we can use, and that's the one where I was telling you the fenofibrate. That's the one that you will see that we use with statins more often. Again, we are still going to check the LFTs because there's these two things we don't want to use together ever, but this is the one that is approved to say, yes, you could potentially use it. Warfarin popping up again, you see that increased risk of bleed with that warfarin. And then looking at your contraindication, if they have any renal or hepatic issues, biliary tract disease, again, with the excretion, things like that, we're worried about those medications. If a patient is taking fibrates but not at gold, can you add ezetimibe and the PCSK9 inhibitor? Yes, you could start to stack on top of these. That would be a very complex patient that would likely not be an issue for you to deal with. But yes, you can stack on top of a fibric acid. You're thinking of it the same way that you think of a statin. It's only used though if the person couldn't tolerate a statin. So yes, is to answer your question, yes. All right. Next slide. Looking at now our niacin, so different, not the same thing as your fibric acid. Niacin is a vitamin, so vitamin B3. And the way that it works is it stops that VLDL formation and secretion, which is what carries our triglycerides, and it can be turned at that point into LDL, which is bad, right? We said we didn't want LDL. You do see that we have an increase in our HDL, but again, what we run into with this drug is going to be our side effect profile. This is something that is equivalent to like a low intensity statin because we do have a decrease in the LDL, but it's not just fantastic. Benefit, good for raising HDL levels. Again, this is not something that we would just prescribe to increase HDL levels. And then good for lowering those triglycerides. Pregnancy, if we know that someone is pregnant, we should not be giving them niacin at that time because we don't know if it's beneficial or not. So stopping it, other options that we have, the lifestyle modifications, potentially our fibrate. Clinical use, again, this is for our patients who can't use a statin, but this is like after I would use a fibrate. Okay, one of our, this is again because of the side effect profile, we don't love to use it. You can see that we use these with our resins. Very rarely will we see it used with a statin, again, because of us not being able to push it over that threshold and because of the increased side effects that we'll see with it. But it is a possibility. So that's where you see it in combination with that statin there. But you can see it used with the resins. So our adverse effect as to why we see a lot of people who can't use it. A lot of people will experience that flushing. And it is, some people, you will see them turn red. You will see that they start to tell you that they feel very warm. Their LFTs, or those transaminases, will start to go up as well right after they take it. When you see this, sometimes people do become like over time they'll say, hey, like it's not that bad. Some people won't get to that point because they will experience it every single time that they take the medication. So, what you can do is you can give aspirin prior to them taking the medication, and it can help with the flushing. You can also give them an extended release or have them take it with meals, and that'll help also decrease the amount of flushing that they have. So, again, ways around it, but you know how I tell y'all, if you have to give a med and they have to take something else, we don't really love that. So if you're looking at this and someone is complaining about the flushing, niacin is not the way that we would want to go. You see the liver toxicity there. That sustained release is having a higher incident than others, which is a little different. So just because it's hanging around for a longer period of time, you're more likely to see that liver toxicity. Hyperglycemia. This is important for you to think about because your patients who have diabetes already have high levels of glucose, which is your hyperglycemia. So if someone is uncontrolled, meaning you don't have their diabetes under control, then niacin is not a good route for you to go. Our controlled release of niacin is less likely to cause the hyperglycemia. So, if we did have a diabetic patient, even our controlled diabetic patient, we would want to choose the sustained release for those patients. And then your hyperuricemia. So, hyperuricemia is essentially high levels of uric acid. We'll talk about gout in this block as well. So, again, being very cautious with your patients who have high levels of high levels of uric acid, or who have gout as a disease state, because now you could increase their risk of having flares because you've increased the level of uric acid in their body. Okay, so make sure that you're paying attention to your diabetic patients and your patients who have gout or high levels of uric acid when we're talking about our niacin. We don't want to do it. Question, is this the niacin that's in energy drinks? Yes, yes, you will see this in energy drinks as well because it helps us with energy, niacin, vitamin B3. And now you know that it also helps you with high levels of LDL. So next slide is looking at our, did it go? Did it turn? No, it didn't turn. Looking at your patient, again, side effect profile, why we don't love to use it. So my patients are having a hard time taking this medication, right, because of the adverse effect. I can't get them to these doses. You see, these doses are extremely high. And this is in divided doses that they're taking it, but this is grams that they're taking, a minimum of 1 gram a day. So with that, you see that they can have a lot of flushing that happens even if you give them several divided doses. And why would I want to take these doses over several, like 4 or 5 times? Remember, we said the more you give it to somebody or the more they have to take it, the less likely they are to take it. So that's why we don't really love to use this. Contraindications, liver disease, gout, your uncontrolled diabetic patients should be there as well. Peptic ulcer disease, any type of hypersensitivity to the niacin, you don't want to use them. LFTs, baseline every 6 to 12 weeks, because remember, I am prone to have liver toxicity, especially if I'm looking at that sustained release formulation. And then every year, just getting that full workup is something that you should be doing anyway with your patients. Anytime you're monitoring this, you're going to get a full workup. See, you got me on the energy drinks, and now I'm talking about workouts. So just pay attention to this when we're looking at our LFTs. You see, these LFTs are being monitored more than our statins, because we're saying every 6 to 12 weeks in this situation versus our statins. We said we were going to do baseline if they complained that first 4 to 6 weeks, and then if we had any issues, and then every year. This, you're doing this every 6 to 12 weeks for your patient. All right, bile acid sequestrants. When we look at our bile acid sequestrants, different drug class, mechanism of action, what they're doing is your bile is made from cholesterol. So after production, they get bound from circulation by these drugs, which causes the liver to say, hey, let me reuptake this. And they'll take up that cholesterol to then make more bile. So essentially, these are not things that are absorbed. We are going to excrete them whenever they use the restroom, but they're just trying to essentially get there and get all of this cholesterol converted to bile acids instead of going out and floating around in our system. Okay, so the bile comes from the cholesterol. So now we're trying to essentially make more of that bile acid and get it out of us. Okay, so it's a safer route. So that's your mechanism of action. Looking at your actions that we have. So again, comparable to a low intensity statin, which was the same thing that we said when we were talking about our niacins. And remember, we also had fibrates. So this is, again, the same use that you could see as to why we're using a bile acid sequestrant. They can't tolerate a statin for whatever reason. Here's something else that we can do to lower their LDL. Small bump, unlike our niacin, a small bump in the HDL increase. You also see here something that we may not want to see. You see an increase in triglyceride concentration. So if my person has high LDL and high triglyceride levels, this might not be the best thing for us to use. Okay, we might not want to use this, because if I have high triglycerides and I give them something that can also potentially increase the triglyceride level even higher, and they're not controlled, that's an issue. You see that mortality benefit again, like we saw with our statins. So that's very good that we see that. Your clinical use, again, can't tolerate that statin. You see this if somebody has diabetes. We'll see sometimes where we have bile acid sequestrants added on board for those patients as well. And then you can see that it can reduce the half-life of some of our medications, because it will also get rid of those medications. Okay, so when we look at this, your big thing is to think, hey, this medication, because of our mechanism, this medication isn't absorbed. It's helping us get rid of things. Therefore, you can see if I want to try to get rid of meds. So let's say somebody had some type of toxicity where they took a high dose of something and we're trying to get it out of their system. Sometimes you'll also see us use a bile acid sequestrant for that. So our different drugs that we have here, cholesterol, cholestyramine, and your cosavalum, are different drugs that we have that are bile acid agents. You see that we can use these in pregnancy, and you can think about that and kind of relate it to the fact that we said that that resin doesn't get absorbed, right? So then, hey, if it's not absorbing, that means that it's good for my baby. Don't remember these doses. Just again, understand that we can use them in our pregnant patients. Um, your Colsavelum, this one has less GI irritation than your older meds. So just remember that as well. Looking at our adverse effects, I just told you something about your Welchol or your Colsavelum about it having less GI issues. That's because your other two have a lot of GI issues. So you'll hear your patients, and again, kind of think about it, right? It's not absorbed, it's sitting there. And so when you think about that, GI distress, constipation are things that'll come along with that. The bloating, and a lot of your patients are going to complain about that. 40% of your patients is a lot. And a lot of your patients are going to stop taking it because they have these issues. If your patient has the issue, just tell them to come back and talk to you, educate them so that they know, hey, they still need something on board. And now you can give them a different medication because they're not tolerating the bile acid sequestrant well. A lot of fluids are very important, and you're going to need to give them that bulk type of laxative to bulk up their stool um, so that they can use the restroom if they do experience that constipation. Decreasing the absorption of our other drugs. So you see the different examples that we have here. So your fat soluble things, beta blockers, thiazides, those sound familiar. Warfarin, your folic and ascorbic acid. These things will not be absorbed properly because remember we said that one of the properties that we had a clinical use was decreasing the half-life of some of our other medications. So this will decrease the half-life of those medications that you see listed there. So you would see that 1 hour before you could administer it. So that's essentially saying on an empty stomach, or you could wait 4 to 6 hours after you have given that bile acid sequestrant for the medication to be given. Contraindication, if somebody has triglyceride levels that are over 400, which is high, you don't want to give it because remember we said that we could increase the level of triglycerides when we were initially looking at this drug class. So if someone has levels that are already over 400, no, we're not giving it to them. All right, the famous ezetimibe. So remember, once we had somebody and they were on their meds, on their statin, and we got them to the maximum tolerated dose, and they're still not at goal, which was less than 70, you saw that we could add our CAI or our ezetimibe. What this is doing is it is inhibiting the absorption of cholesterol from exogenous and endogenous sources. So what I eat and what my body, what my liver is making, it's trying to say, hey, let me get rid of that absorption. So it's working at that brush border to say, hey, intestine, we're not going to absorb this cholesterol. We want to get rid of it. So even if they're not eating it, remember we had that endogenous source, their body is still going to try to say, hey, we don't need that. Let's get rid of it. So very similar to what we've been seeing before, low intensity, it says statin. It's supposed to be a statin, equivalent to a low intensity statin for lowering those LDL levels. You see a slight bump in your HDL, and you could potentially see some benefit in lowering the triglyceride, but not big enough to where you would solely use this for lowering triglyceride levels. Adjunct to our statin therapy, right? So we already talked about that, decreasing your LDL in some of your patients. So this is patients who have a history of hyperlipidemia, or they get diagnosed with familial hyperlipidemia. You'll see that we can sometimes initiate this medication at the very beginning. There are some people who no one in their family can tolerate statins. You'll also see us use it here. Don't use it in your pregnant patients. Remember the bile acid sequestrants 2 hours before or 4 hours after you take this medication to make sure that it is absorbed properly. And then you see here we have combo with statin. So now instead of you increasing their pill burden, you can give them a combo drug These sometimes are on our formulary and sometimes they are not. Vytorin usually is. So worst case scenario, you give them simvastatin. Usually now, again, we're away from simvastatin because of its side effect profile, but you give them simvastatin or atorvastatin, and then the ezetimibe can be added on board. Right now, we love rosuvastatin and atorvastatin more than that simvastatin. So again, just understand that those are options. If you have a patient who you know is not very compliant, we want to give them the combo because it's just easier for them to take one drug. What we do see is if somebody is having any type of myopathy, muscle pain, anything like that, that this allows us to decrease that dose because now we have some action coming in a different way to decrease that LDL level. So that ezetimibe is like, hey, you're experiencing some muscle pain. Let me add this on, and that way I can lower your statin dose and give you the ezetimibe. Our PCSK9 inhibitor. So this was like your last ditch effort, right? You tried your statin, you tried your ezetimibe, your CAI, it didn't work. So you end up at a PCSK9 inhibitor. Some places have keys on this, some don't. Again, this is like your elevated patient. They're a very complex patient. Most of the time, this won't be your problem. But PCSK9 inhibitor stands for proprotein convertase subtilicyline kexin type 9 inhibitor. As you see, PCSK9 inhibitor is way easier to say. So, what it is doing, the PCSK9 enzyme is normally binding to your LDL receptor to promote your LDL receptor degradation. When we inhibit it, which is what this class is doing, that LDL degradation gets promoted because now your receptors are around for a longer period of time. They're not being degraded by the PCSK9 inhibitor or enzyme. Okay. So your PCSK9 enzyme typically says, hey, LDL receptors, get out of here, right? They degrade them. So if I inhibit PCSK9, which is what this drug class does, now I don't have the degradation of my receptors. And so now I can bind to more LDL that is circulating. All right. So then they'll grab that LDL out of circulation and then we'll get rid of it. Okay. So this is also what you'll hear receptor recycling. So results in increased LDL cholesterol clearance, which is what we want. We want to get rid of it. All right, our drugs that we have. Very effective medication. We get some mortality benefit. That's always important. Always make sure that you remember that your patient should always practice, any of our patients with this disease state, in any disease state for that matter, should always be practicing good diet habits. Okay, so if you need somebody to talk to them about their diet, you can always put in a referral for them to go to nutrition as well. And we'll talk about that a lot with our diabetic patients. But this is another disease state because those are the habits that are very hard to change. Um, Adverse effects that you see, you have different issues with like the nasal passages, injection site reactions, flu-like reactions, because these are both going to be sub-Q injections that your patient is taking. Okay, so again, sub-Q injection, I need you to remember that route because your patient might not want to do that, right? So you see your alirocumab, which is your Praluent, and your evolocumab, which is your Repatha. Both of these were on the formulary last I checked. You see that they're injecting themselves twice a week. With your Praluent and your Repatha, they get to do it twice a week, or they can do it once a month. So for some patients, that could be your selling point. Like, hey, you're only doing it twice a month, and it's going to help you get to those doses or to those LDL levels that we want you to be at. But again, depends on your patient. If I tell you that I have some type of aversion to needles, not the option for me. But again, it might be important for them if they can't get their LDL levels under control. This is the option that they have. You do see that this is a expensive medication, right? Upwards $500 to $1,200, $1,500 per dose. So again, just be very aware of that. Costs a lot of money, last ditch effort kind of drug, and when we're using this. All right, omega 3 fatty acids. When we look at this can be over the counter. Some people take these as dietary supplements. They're good to decrease the triglyceride levels that we have. Just make sure that you pay attention to an LDL level also, because sometimes these can increase the LDL levels. Um, Increase in that HDL level. We're not worried about HDL increase, because remember, we like when our HDL increases. Mechanism of action unknown, but what we think is happening is that it's decreasing the reduction of triglycerides being produced by the liver, is what I need you to remember. And then you also see the increase in the hepatic beta oxidation happening. So essentially, targeting your triglycerides is where we will see your omega-3 fatty acid. Safe for us to use this in our diabetic patients to lower triglycerides, unlike our niacin. Remember, our niacin, we weren't going to use those in our diabetic patients. Looking at the prescription products. So some of these continue to come on and off of our formulary. So just before you order, you can go to the TRICARE formulary lookup tool, and you can see what the flavor of the day is once you're trying to order. So looking at your formulations, you have your omega-3 acid ethyl esters. This has EPA and DHA, which are two different forms of your omega-3. I just need you to remember it that way. That's it. Like, I'm not going into all of that, but these are your two different types of omega-3 fatty acids that we have. You can see that the higher the dose that we use of this medication, we can have platelet, how do I want to say it? Inhibition of the platelet aggregation. So that means that you can have an increased risk of bleeding, especially if you are having somebody who's already on DAPT or anything like that, because they're already going to be inhibiting those platelets. Okay, so anybody that's already on antiplatelet therapy, you have issues there. Pregnancy. If somebody is a high risk pregnant patient, you can consider using your triglyceride or your omega-3 fatty acids in that population. Vasepa, you only have your EPA, that's your icopacent ethyl, that you could have just EPA there. We're using this with diet, exercise, like I told you already, to decrease those triglyceride levels. Again, you can consider using this in your pregnant patients. We have different dietary supplements that are over the counter and omega-3 over the counter, but we can prescribe it to our patients if it is on formulary, and it's better for you to do that because we know exactly what is in the medication. These had to go through FDA approval, right? So it's better for you to prescribe it if we can prescribe it. Adverse effects. Big thing that people will complain about is that whenever they have gas, especially when they belch or burp, it will have a fishy smell to it, and they will have that fishy taste kind of linger around. Remember that an exogenous source, another exogenous source besides them taking a capsule, is from like fish, so like tuna, salmon, things like that. So you can kind of relate that to the adverse effect, even with the capsules, is because they're coming from that fish oil. Um, Also, looking at this, making sure that your patient doesn't have an allergy to fish or shellfish, because they can then run into an allergy because this is coming from, again, the fish oil. And then those antiplatelet, anticoagulant medications, anything that's dealing with bleeding, we can see an increased risk of bleeds if they're taking the higher doses of these medications. So just make sure that you're monitoring your patient for increased risk or increased bruising. If you're having somebody who's on warfarin or you're monitoring their levels, make sure that that INR and all that stuff is not going up for your patients. All right, your bulk forming laxative or your physalim, Metamucil. We talked about this last semester. When you're looking at this, you can see that we have some LDL lowering capability as well. Not the first thing that we would reach for, but it is, an added benefit if you did have somebody that was taking one of your bulk forming laxative. Adverse effects, same things that we talked about before, that gas that they can experience from taking the medication. This is just looking at some of our treatment options that we have for our patients who, for whatever reason, can't tolerate a statin, our high intensity statin you see where we have our low intensity that can be here. Your non-statin things are again those patients who, for whatever reason, they are not able to tolerate a statin, or they are taking the statin and we need to add on to get them to achieve that LDL goal of less than 70. Those are when you can see these things added on. So I just want you to pay attention to those. Over here with your triglyceride level being 500 or higher, remember that we like our omega 3s for that. You do have niacins in your phenofibrate, but remember what is going to interact or more likely to interact with our statins, and trying to remember which ones you would pick in those situations. If your back was against the wall, you had no other options, just remember you're going to be monitoring that CK, the LFTs, a little bit more often than you would have had you not had them on both of those medications at the same time. So this is just a summary of all of the other things that we've already talked about, making sure that you're taking into consideration the pregnancy status and if your patient is trying to become pregnant. So an example question that we have, which of the following medications is most likely to cause myopathy or rhabdo in a patient who is taking our simvastatin? And so when we're looking at this, we already talked about our gemfibrozil. We would want to use the phenofibrate if we could use one of them, or if we had to use uh, a fibrinate acid. And then you have your omega-3 acids. That one was particularly, we didn't have any big issues with it. And then your ezetimibe, that was what we were adding on to our statins if they couldn't tolerate. And then your PCSK9 inhibitor, again, we were adding on to our statins if they couldn't, adding on to our statin or if they couldn't tolerate. The second question, your 77-year-old male with hypertension came to the clinic for a cholesterol screen. He's recovering from an MI a year ago, so that means that he has had an ASCVD event. His LDL is 150, his triglycerides are 125, his HDL is 29. Most appropriate treatment that we want for this patient. So when you're looking at this can be a tricky situation. We see that this patient has had an ASCVD event. He also has hypertension. So you could put him on a moderate or a high intensity statin. The reason why in practice I would put this patient on a high intensity statin, even though I'm looking at his age, is because his MI was very recent. It was a year ago, right? And his LDL level, we already know, which is why we're even looking at a statin, is high. He's not close to goal. He's not close to 70. And so I would want to probably treat this patient more aggressively. Also, he doesn't have enough of that good HDL floating around either. So I would treat this patient more aggressively than I would. But if he didn't have that recent I would be like, oh, let me give him that moderate intensity statin for this person. So again, just make sure that you're looking at your patient as a whole and remembering those two charts that we had at the very beginning. Um, Remembering that, hey, that person, this patient that we're looking at, the 77-year-old patient, he recently had a MI, so he goes into your secondary prevention chart. Your moderate or your high intensity statin is reasonable, but because he was so high risk, meaning that was a recent MI that he had, that's why I was telling you. And his LDL level was over 70, which is clearly why we were doing it. That's why I said I would more likely lean towards that high intensity statin, because this is a very high risk patient. Okay. So you walking your way through it, secondary prevention for him, not primary, because he's had an ASCVD event. And then going back to you remembering what your statin levels are, your moderate, your high, answering that question, if you were to look at that, you're going to pick your high intensity statin. So you have your atorvastatin or your rosuvastatin are the two that I told you are high. But again, remember I told you you have to remember the doses for these. So your atorvastatin 40 to 80 is high intensity, and your rosuvastatin 20 to 40 is high. So that's why your answer here would be E and not C, because your answer C is moderate intensity, and we're going high for this person. And our what do we know? Again, some of our class effects of niacin, those side effects, flushing, GI issues. Remember, we would try to give our patient the aspirin, pre-treat them to try to knock out the adverse effects that they're going to experience from the niacin. But if somebody is experiencing that, we kind of don't want to do that. We can also give them meals. We can also get them titrated up slowly, the controlled release, several different options, decreasing the dose potentially, seeing if we still get that benefit that we wanted to see. Our high intensity statins, AR, okay? Remember, your atorvastatin starts with A and it's your higher dose, so 80 to 40. And then for your rosuvastatin, cut that in half. 40 to 20 are your doses, okay? Your dose range. And then when do you check your CK levels with your statin use? At baseline, and then if your patient complains of any other myopathies while they are taking that medication. Then you have your memory jogs. Again, just make sure that you're looking over them to see kind of what are the main ideas that you would have. I know y'all are going to look at me crazy, but I have 6 minutes and I want to chop off time in the back. So what I was telling you about the antiarrhythmic lecture, if we can pull it up real quick, is just going to be the intro.